Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. I'm your host, Dr. Kevin Hopkins, a family medicine physician at Cleveland Clinic and physician director of health system engagement here at the AMA. What does the word autonomy mean to you? Many physicians, in fact, I would wager most physicians, desire more autonomy related to their work. But what would it look like for you to have a higher degree of autonomy in your job than you do now? My guess is the ways in which physicians would answer this question would be highly variable. Some of us might want total control over our clinical hours, or it might be more important to have more say on appointment length or amount of time we can spend with each patient. Others may be looking for greater influence and the ability to advocate for themselves and their team when it comes to their workload. Maybe it would be more valuable to you to have an additional week of vacation than a salary increase this year. In an article published in the Annals of Internal Medicine in November 2024, authors, including several from our AMA professional satisfaction team, wrote that for physicians, a lack of control over patient load, team composition, clinical schedule, and workload are each independently linked to burnout. Despite our desire for greater autonomy, physicians continue to move from privately owned practices to being employed by a larger organization, such as a physician group, a health system, or a health insurer. Dr. Mark Greenawald has been our guest on the podcast before. In October 2024, he and I did an episode called How to Be Employed Well. Be sure to give that a listen if you haven't already. Today, he joins us again to discuss the value of autonomy to physicians. Dr. Mark Greenawald is a good friend and colleague, currently serving as the Interim Chair of Family Medicine at Carilion Clinic in Virginia. Mark, thanks so much for being a repeat guest on the podcast.
Kevin, it is an honor and a pleasure to be here and look forward to talking about this subject. Excited to explore this with you.
So before we get into our topic of autonomy, would you mind telling our listeners a little bit more about yourself and your background and how you got to where you are in your career?
Glad to. As Kevin shared, I am a family practice physician here in Roanoke, Virginia. I work at Carilion Clinic and the Virginia Tech Carilion School of Medicine. I'm presently in an interim role. My previous role was as vice chair of academic affairs, well-being, and professional development for our department. I also serve as our medical director for the Carilion Clinic Institute for Leadership Effectiveness and have a deep passion for both leader development as well as clinician and care team well-being and creating deliberate and intentional culture. So lots of different interests and many that really come together around the topic that we're going to be talking about today.
Yeah, so Mark, you're an expert in all things that we're going to touch on today, so appreciate your expertise and your willingness to share it. So let's get into it. Autonomy. What does that mean to physicians today, Mark?
What I've learned as I've started asking that question, as you pointed out in your introduction, it means different things to different people. When you look at the actual definition, the dictionary definition of autonomy, it means self-governance or self-determination. And I think most people would say, if given the choice, I would prefer more of that to less of that. And what we also know, of course, is that autonomy is just one aspect of a greater conversation. So when I think about autonomy, Kevin, I was really first introduced to this concept in the context of healthcare through the pillars of biomedical ethics. So I learned about it we learned about beneficence and non-maleficence, so help and do not harm, and then also autonomy and justice. And so I first learned about autonomy in the context of patients and patient care. And what that meant is the patient had the ethical right to expect that they would have say in the care that they would provide. And I remember even back then, as I was learning these things, really as a resident, that I was disturbed as a family practice doctor that I had my individual patients who I cared for, and I was really taught that my job was to optimize their needs. So I was to take responsibility for what they needed, and I was to optimize that. And I didn't learn the flip side of that, which is the dynamic tension that has with the population. So if I'm advocating for a scarce resource for my patient and aggressively doing so, what does that mean for other patients who just happen to not be mine, who also need that resource? And so that gets into the idea initially of what does it mean for individual patient autonomy versus what does it mean for the collective, if you will. And that got even further when we talk about it. Does it autonomy mean that a patient comes in and says, I want this? And if I educate them and say, here are the pros and cons of that, even if it's something that we think is dangerous, does autonomy and the respect for autonomy mean that they get to do whatever they want?
Yeah. Is it a fast food drive-through order? Have it your way.
I need a CT today, and so really thinking about that, and then as I've moved more into leadership roles over the last 2 decades, becoming engaged in the conversation for clinicians, and the idea that the default is always, and when we talk about well-being and clinician distress and burnout, the default is always more autonomy equals weller, if you will, that I'm moving more on the continuum toward thriving as I have more autonomy. As you pointed out, as more clinicians choose to be employed in some capacity, there becomes this dynamic of what does autonomy look like in the context of being organizational or being on a team. But that has really had me thinking about how do we live as clinicians in this dynamic tension, as clinician leaders in this dynamic tension, as administrative leaders in this dynamic tension.
Thanks, Mark, for that. It sounds like what I'm hearing you say is that control over our work doesn't have to be all or nothing, which is probably what most of us think, that it's either all or nothing. And just like for our patients, complete autonomy might not be the best for them. Complete autonomy for us as physicians might not be the best for us. And so drawing that parallel, sort of as you started it out, thinking about how we do shared medical decision-making with patients, perhaps shared decision-making in our work as physicians, in the context of our employment or practice setting, maybe that's a better model for us to think about autonomy. Am I rightly reflecting what I heard you say?
Sure. I like the way you phrase that. And two analogies that I've thought about, one which is a very simple analogy, thinking about what autonomy means along a continuum. If I'm driving alone on a rural highway and there is no one within miles of me, and I choose to say, I just want to go as fast as I can in my car, and therefore I'm having kind of ultimate autonomy, if you will, that's different than if I have someone else in the car with me. And that's different than if there's the potential of a few other cars on the highway. And that's different than if there's a whole bunch of cars on the highway. And at each stage along the way, I have a different kind of responsibility that goes along with my desire for ultimate accountability. So, going 80 miles an hour or whatever my little Subaru could do is going to look different than if I'm alone than if I am driving in the city. And so that's one way to look at autonomy. The other is to think about autonomy. What does autonomy look like in the context of a team? So one of the things that you and I have certainly been schooled in is team-based care. And I know the AMA is very much of an advocate of that idea of team-based care. On a team, I have teammates. So even if I might say, let's just use the example and say I am the captain of the team. Well, in some ways, by being the captain of the team, I'm actually giving up some autonomy because I need to look out for my teammates in a different way. But either way, I need to figure out how my desires for self-governance or self-determination also intermingle with those of the other members of my team. And so thinking about that, I often think clinicians, when they think about autonomy, they also think about this in the way I've kind of tongue-in-cheek have said that often when clinicians think about being employed, what they really are saying is, please provide me a building, the staff, the technology, a salary, and then let me do my thing. And that doesn't quite work that way. And so what is the trade-offs that we're deciding to make as we bring on other members of the team? How do we as physicians, if we think autonomy means essentially leave me alone to do what I've been trained to do, what does that mean when it comes to being part of a team, having partners, being part of an organization? And that's where I think the conversation gets more nuanced. And I think that's where it becomes more important, is saying, yes, autonomy in general, I think we can say more is better to a certain degree. And where is that line then, which is something I struggle with every day as an organizational leader, when I have clinicians reaching out to me and saying, I want this, and somebody else saying, I want that, and I have to staff to those things as well. So something as simple as, why not give me a flexible schedule? Sounds great, and I'm a total advocate of that. If I'm optimizing well-being, the answer is absolutely, I think that's a great idea. And yet, what does that mean for staffing that? And what does that mean if you have partners who want a different schedule than you? And so I look forward to continuing to explore that with you today.
Yeah, great points. I mean, all examples of situations in which we have to think about, especially for health system leaders, how we can tailor autonomy, individualize it, and make it relevant to each individual person while still meeting the goals of the practice, the goals of the organization, all of those things. A couple examples I thought of recently is I needed to make some changes in my clinical schedule. I needed to change my Saturday clinic for this month to a different Saturday, for example, and I needed to change a couple of other things relative to my clinic session. And it's easy for me to think, well, that really only affects me. But it doesn't just affect me. It affects our clerical team at the front desk. We need to make sure there's adequate staffing there. I need to check with my nurse, without whom I wouldn't function very well in clinic. And so is she available on those days? And so I found that we needed to discuss those things as a team because my nurse had some limited childcare options on certain days. And for those reasons, we went away that maybe wouldn't have been my first choice, but it was better for the overall team. So are those the type of examples you think about and hear about?
All the time. Yes. There's also all the patients who are on your schedule for that day. So unless you're seeing acute care, there were patients who were eager to see you and now need to be rescheduled. And so in some ways we are violating their autonomy, their ability to see their physician. So yes, it is about trade-offs. And that's the piece that I think is a wonderful place to have the conversation in saying, if you think about it as a continuum, in some ways within an organization at least, there's a sweet spot in the middle. And the middle has to do with collaboration. It has to do with how we structure things and how rigid are those structures. It has to do with, kind of hybridizing some of the things that you do, but within boundaries. And so how do those different things all come together? And what I find is we clinicians, when we chose to be employed, we did agree to some trade-offs, and I'd like to explore those more with you because I'm not sure we were always conscious of that. And I think we also don't think about how we can leverage that in some ways to elevate our autonomy even within the context of employment, again, thinking along that continuum. And yet, we also know that in some ways we voluntarily gave up some autonomy so we could have some other things that we wanted, such as a salary, such as a more structured call schedule, such as staffing and HR issues that you don't need to worry about as much as you would if you were running the business. And one of the things that came to me as I was thinking about this was just the idea of risk. And if you think about, again, an autonomy continuum from kind of full dependence all the way up to whatever we might decide is kind of the ultimate state of autonomy, as you move up that continuum, you are willing to take on more risk. So if I'm totally dependent, the risk I'm taking on is whoever I'm dependent to will be benevolent in some way. And if I'm all the way over on the independence side of that, I'm willing to take on more downside risk. And by being employed, most of us have decided we're going to live somewhere in the middle, maybe more toward risk, maybe less toward risk. And what I found even in my role presently is that also depends contextually on where somebody is in their own career. That at some phases of a career, when I have new grads coming out, we guarantee their salary for the first 2 years in our compensation structure. Why? Because that decreases their risk as they start out and build a patient panel and start to build a practice and get used to increased volume and things like that. And then at some point, they say, I'd like to take on more risk in order to more optimize my potential income. And so in that case, they're moving a little bit more on the scale in some ways or on the continuum in some ways. Again, where do we find that sweet spot? And that what I've thought about often as a leader is how do I set the limits for that? And that is a really exciting space to invite physicians into. And that becomes part of the autonomy conversations. How can they optimize their autonomy within whatever structure they have agreed to be part of? The first step, I think, is understanding what you signed up for in the first place.
Yeah, that's the basic structure. What's the institutional standard, I think is what you call it. I'm a big fan of giving people guidelines and guardrails and then giving autonomy within those.
Absolutely. And if you want to increase autonomy within an organization, tell our clinicians this all the time, get involved in the conversation. Express your opinion and understanding within an organization how that happens. So what is the organizational structure that will allow you to get your voice heard in the most effective way? Then as you have the opportunity to have your voice heard, be very aware of how you're using that voice. So, are you pounding your fists and demanding, I'm a physician and I want this? Okay, I've seen that approach, and I'm not sure that that's a particularly effective approach. It certainly hasn't been with me. Or do you engage people in conversation? Do you come with data? Do you come with ideas? Here's an idea I have, to pilot something. We're doing that right now with call. We're looking to pilot some call coverage that's different than what we have done literally for the last 20, 30 years because somebody came with that suggestion and said, I wonder if we might consider doing this differently, and came with some data around that. So those are ways that I think physicians, if they are employed, can increase their autonomy in a very different way. The other piece that I find is, to a certain degree, whether we're on a team or whether we are physicians as part of a care team, we earn autonomy to a certain degree. So what I tell my clinicians is that particularly the ones who are incredibly productive in the context of how they see their patients, how they do their quality metrics, and they're also loved. And what I tell them is, I don't want to mess up your rhythm. So when we come out with these new things, I'm not talking to you. Like, you're okay. You've earned autonomy by being a good teammate. We use the term organizational citizen. I'm not sure I like that as much as you're a good teammate. I'm not chasing you every week to get your charts done, to get your labs reported to the patients. So you earn that by, as you pointed out earlier, Kevin, understanding the boundaries and then doing well within those boundaries. And so I think that's a way to begin to earn autonomy. The other way, of course, is engaging your administrative partners and getting them to understand a little bit more about what it's like to be a physician. Many of them have never been in healthcare at all. Some have, but in a very different context. So helping them to understand what your perspective is and why is that important, not just for my own selfish interest perhaps, but for patient care. Why is having a little bit more control over my schedule important in terms of providing quality patient care? That feels very different in a conversation than because I want it that way. I've always done 15-30 schedule, and so that's the way I want it. Well, again, we have to be willing to be flexible and understand why it is that we're asking what it is that we're asking, and not just be insistent about it because that feels better for us.
Yeah, because I think it's really important. For most of us aren't leaders in health system. Most of us are frontline physicians, and so how can we favorably influence our ability to have perhaps greater degree of autonomy, even in an employed model? And I know you talk about being organizational, and you just mentioned being a good organizational citizen or a good teammate. So what I heard you say about how we can do that is be aware of our role as a leader. You don't have to have a title to be a leader. Physicians are leaders, whether you want to be or not. Engage in the conversation around autonomy, particularly with administrative colleagues in your practice or organization. Think about the data that support your ideas, suggest pilots on how we could make things better and be involved in the process. And then that autonomy is earned by, like you said, being a good teammate and sort of being consistent in how we show up every day. And I'm not just talking about productivity and revenue and those types of things, though that certainly is part of it, but being a consistently good partner and teammate. Did I miss anything in what you said, or any other ideas on how we can advocate for ourselves towards more autonomy?
I think you summarized that really well. And I would add to that, thinking about what does the organization need? So we can look at things through our lens in terms of what do I need? What do I want? What is it that the organization wants, not just from me, but from us in the collective? And the more I can see and understand that lens, the more effective I'm going to be in terms of engaging organizational leadership in the conversation in a manner in which they can hear it. So really no different than saying, as I sit down with a patient and talk to them about a clinical issue, I change my language. I adapt it and flex it based on where I think they're going to be able to best comprehend what it is I'm trying to say. It's the same thing from an organizational perspective. And that's where I think using sometimes that's a big stretch for people who are really mostly clinical, that they're spending their time. And that's where I think utilizing your clinical leadership, hopefully your physician leadership, and my hope is that they're learning both those languages so they can serve as a bridge or serve as a translator between those two. And that's a hard place to live. And yet that becomes an important part of what we do. So we don't end up either having the organization look at us and say, yeah, Mark's just digging in for, all he can see is what the clinicians want. He can't see the perspective of the organization, or going too much to the other side and becoming what our colleagues might call a suit and saying, you've forgotten what it was like to be one of us. We have to live in that intermediary, in the middle of that dynamic tension, which I find both challenging and also incredibly rewarding, because I think that's where you can get a lot of things accomplished as people start to understand differently what those perspectives are and what those needs are of the different groups.
Well, in practice, and health system leaders are so used to hearing complaints, but when you come with a potential solution, or at least an idea, that's a different type of quote unquote complaint. It's an idea, it's an opportunity. And so health system leaders tend to respond to that. So we talked a little bit about how individual physicians can sort of advocate for more autonomy with the great suggestions you had. Thinking now, flipping that as a health system leader, identifying things like lack of adequate work control is associated with a 4.5 times burnout rate compared to physicians who perceive that they have good control over their work or great levels of autonomy. 2.5 times the intent to reduce their hours or leave an organization for physicians who report lack of work control. We also know through research that feeling valued by the organization for which you work is inversely associated with burnout and with the intention to leave that organization within the next 2 years. So thinking about this from the perspective of a health system leader, what can practice or health system leaders do? What can we start to do to provide more individual physician autonomy?
Beautiful question. Thank you. And it is both. What can organizations do and what can we do? And so I think we do have to look at it from both sides. Kevin, I want to start with the idea of being valued. What can organizations do that may not directly relate to autonomy, but it does relate to well-being? And what I've certainly learned, both by being a physician and by working with many and seeking their feedback and input, is often organizations, when we use the word valued, they use it very differently than what I think physicians are talking about. So, organizations often think that value is about, let's have a celebration for Doctors' Day, and we appreciate you. And I don't doubt their sincerity in their appreciation, but for most physicians, they would say that falls pretty short of what I'm talking about. What I'm really talking about is, am I being recognized for the expertise that I bring into this organization? Am I being recognized for the patient care that I provide? And that has to do with just literal recognition. Kevin, I noticed last month that your patient care, your satisfaction scores were really quite impressive. And I just want you to know that's noticed and appreciated. That goes a long way. Not just, yay, we appreciate you, Kevin, you're one of the team, but literally saying, Kevin, this is what I'm noticing. And the more I know what you value, and the more I can customize that as a healthcare leader, the more impact that will have on you in terms of your sense of feeling valued. Again, not necessarily directly corresponding to autonomy. So let's talk about autonomy for a moment. So looking back at the article that you referenced at the beginning with Krasinski and colleagues, where they actually looked at the organizational biopsies, the instrument that the AMA uses as part of their health system work. And they talked about a few in there that they found in this study were directly related to decreasing burnout and increasing that sense of autonomy. And they talked about including things like intention to reduce hours of practice and intention to leave. And they found that as physicians had more of this or were more satisfied with this, it's not necessarily more of, but more satisfied, the less they had the intention to leave, the less burnout they had, the less they had intention to restrict hours. And those included things like the control over volume of patients. So I come back to, as a leader, saying, what do we know about, so as we look around the country, as I talk to colleagues, what are the trends that we're seeing? From a financial perspective, what is sustainable based on what we know, the revenue that comes from that work, and then really sitting down and helping clinicians understand where that comes from. So, I'll own some things that happened here where we had to make a change and start becoming a little bit more stringent about what schedules looked like. And we had to become a little bit more aware and having oversight about making sure schedules were filled. And the manner in which we initially communicated that was not optimal because it felt a little top down. We started talking about numbers and started to get into people's business a little bit more. And that's where I get back to the people who were already doing that. My job should have been to go to them and say, you guys are awesome. And let me tell you something, you didn't even know this, but you're actually fulfilling a minimum target that we've had, but we've never really talked about very much. But then when we go to others who are maybe seeing 12 patients a day, and we start by saying, help me understand this. Like, are your patients that much different than other people's patients? And so rather than as a physician just saying, no, that's all I can see, what I want to do as a health system leader is to say, how can we help you get to this different place? And to help you, just by example, already 70% of your colleagues seeing the same patient population that you are, a very similar one, have been able to achieve that. So it's not something that's coming from, some draconian idea that's coming from outside the organization. This is something that we've piloted within the organization. We've tested it, and we know that it can be achieved. So how can we help you? And that's where, as physicians, what I often find is that it is those same physicians who often are resistant or reluctant to accept help. So that's where, again, in terms of autonomy, if you get up to that point, I'm leaving you alone. But until you get up to that point, in some ways, you've given up some autonomy because you're not willing to take on some more of the responsibility. It's not just the risk then, it's also the responsibility of what you agreed to if that happened contractually when you came into the practice.
And probably, based on what you just said too, Mark, in order to reach that point, you probably have to give up some autonomy, like delegate tasks that don't need to be done by the physician.
Absolutely. So that gets into then that idea of workload. And, that another one that Sinsky and colleagues found in that study is that workload was the higher the workload, the lower the sense of the more folks felt burnout and tend to leave and tend to reduce hours. And so how do we help? So workload has to do not only with autonomy, but also with interdependence, how do we work as a team? And how do we then delegate in a way that is going to be most effective to allow a physician to have less workload, more than space to see patients and things like that. This is where an organization can help. An example here at Carilion Clinic, we're looking at ways to use AI to help triage patient portal messages. We're looking at ways to streamline medication refills, all those types of things. Those are ways that the organization can help. But where the clinicians can help is, again, the example that I see too often of those who are struggling but won't give up any control. They won't delegate. They feel the need to do all those things themselves. The willingness to flex some and say, I'm going to have to give up some control if I want to move up that continuum in terms of workload. We have physicians now who won't even allow someone else to take their call when they're on vacation. Well, okay, that you could say ultimately they may feel that gives them more autonomy in some ways. I'm not sure their family or their friends are feeling that when they're on vacation. It's like, give up autonomy, okay, because we're here at the beach having a good time. Those are things that I think dialoguing around become helpful. And sometimes we physicians can get in our own way, unfortunately, but really allowing ourselves to learn new things and being willing to learn new things, I think can be really helpful for us.
Mark, as expected and anticipated, great insight and perspective on this topic. And our conversation's been ranging, but a lot of great perspective here on autonomy. What have we not covered? Is there anything that you think would be really pertinent for us to share with our audience before we wrap up today?
Kevin, what I would say is that I find at every stage, if we go back to a kind of an imaginary autonomy continuum, I find at every stage along that continuum, there are physicians who are thriving and there are physicians who are totally fried. And so there is not one model that is going to fit everyone. And that's where getting into the conversation, first of all, doing the introspection to understand what would be a model that would work best for me. And what do I need to be in a best position to thrive? And I need to advocate for that after understanding that. But it is important to remember there's not one right answer. And even for any of us, that's going to change over the course of our clinical careers. And so keeping our own finger on the pulse of that regularly and getting to the well-being and burnout discussion, understanding when I'm failing to thrive and then being willing to pause and saying, what's going on under the hood right now? Why is this happening? And how can I do some recalibration to get to that place? I think becomes really important. And what I've learned is as physicians take more ownership of their outcomes, of their processes, of each other, organizations are very grateful for that. And you will find that there will be much more collaboration, much more interdependence, and I think much more of a sense of appropriate levels of autonomy. And that, I think, is really finding that sweet spot so important.
Well, certainly a big part of our goal and mission at the AMA is to help physicians thrive, not just survive. And so these are all great tips and ideas for us to consider. We want to help create the conditions where joy, meaning, and purpose can be found in our work day to day. And so thank you for sharing your expertise and experience with us. Dr. Mark Greenawald, Interim Chair of Family Medicine at Carilion Clinic in Virginia, has been our guest today. Please check out the episode description to explore the resources mentioned in today's episode. And until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series, stepsforward.org.